This is Carol from STS. This is the version 4.20 adult cardiac upgrade call for March 26th. We will probably go the whole hour, so from 2 to 3. Sorry, the slide has 2:50 on there. We'll probably go for the whole hour, depending on how many questions we get in. So thanks for joining on the call with me. We have IQVIA staff and Dr. Warmuth, who is the chair of our informatics task force, and hold on one second. The chair of our informatics task force, and then I have some of my STS friends with me, and we have Melinda Offer, who's our consultant who manages our FAQ mailbox for adult cardiac, for the adult cardiac database. So again, this call is to review the 4.20 upgrade. We ended last time with the hemodynamic section, so we're going to start with the operative section, see how many questions we have at the end of that section, and then either answer questions or continue on. We have about 4 more calls before go live, so hopefully we can get through quite a bit of it. I think we had most of our questions were appropriately so for the hemodynamic section. So that took a little bit, but we'll see how far we get today. And if more calls are needed, we'll plan them, but hopefully we can get through the rest in the next 4 phone calls. And then we'll have time for questions either after the operative section and see how many are coming in, or we'll just, we'll wait and I'll take questions about the last 30 or 20 minutes. So again, this for version 4.20, we did hear from some sites that there may be a little confusion, and they had started using the 4.20 data collection form on current cases. Just to clarify, version 2.9 is to be used for OR dates through June 30th, and then version 4.201 will be used for OR dates starting July 1st, 2020. So be sure to, you can abstract on both of the forms if you wanted to get used to 4.20, but for data submission into your vendor software and into the data warehouse, the current version is version 2.9. Okay, so I'll get started here with walking through the form. Please use the Q&A functions to enter any questions, not the chat box. And then we'll get started here. Let me switch over to my screens. Okay, so we're in the operative section now, and I can see some questions coming in. We'll get to those in just a few seconds. Most of them are about
Carol.
COVID. Yes?
Sorry, Leanne says she can't hear you. I'm just wondering if other people are having trouble.
I don't see anything coming in the chat box, so it sounds like I'm coming through okay. Leanne's going to try to call back in. Okay, yep. Looks like they can hear me. They can hear me. Okay. Thank you, everybody. Okay. So first I'm going to talk about the COVID-19 outbreak and any delays or any changes in our scheduling. STS is critically evaluating our timelines and our deadlines related to this outbreak and the impact it is having on sites with people getting pulled from their quality improvement jobs into bedside or things like that. We are evaluating that, and any changes will be communicated out as soon as we have confirmation if we're able to do anything for that, and hopefully we should be able to. So just please, I see the questions coming in. I'm not going to address any more questions on it, just that STS will be communicating out to sites regarding that hopefully shortly within the next week or so. I'm going to go into the operative section now, and we have the form on the left, again, is the blue and yellow. The yellow were the things that were deleted from 2.9, and the blue were things that were added in. So for the status, we added an emergent salvage, and this was a response to some of our TAVR cases coming in, where we would have a dissection, or the patient was receiving, if you had a dissected coronary, the patient had to have CPR performed, and they had to rush that patient to the OR following one of those types of procedures. We would call that emergent salvage, and that is how you get to this failed transcatheter valve therapy for the subacute device dysfunction, or the acute device malposition, or the acute annular disruption. So we added that in so you could collect those there, because oftentimes these become salvage cases. we removed, here we go, we removed the previous case canceled and the reasons for those cases being canceled, and if the current procedure was canceled. That has all been removed. For the initial operative approach, we combined some of these thoracotomy approaches into one thoracotomy option. We removed, of course, the case canceled because we are not collecting those any longer. And then some of these other ones, like the transverse sternotomy or the parasternal incision, subcostal, these had very low, extremely low frequency, so we weren't going to do anything with those regarding quality improvement. If you are seeing these come in as your operative approach, you could select other for these. So again, all of these thoracotomies, including mini thoracotomies, were combined into the one thoracotomy. And then this is going to be the section where you're going to see most of the changes regarding how the aorta procedures are captured. We had to do something a little bit different here. I'm going to switch over to this form on the right. We have the coronary artery bypass, and then we moved aorta above valve procedure for a specific reason. This is, once you get here, you can answer if an aorta procedure was performed, yes or no, how that was performed. And then the aorta, and if anything was performed on the valve, it's all going to be captured in the aorta procedure section. So the aortic valve information, when we get down to M2, you'll see the aortic valve information is duplicated in the aorta procedure for combined procedures. So for this section, if you had an aorta procedure performed and say a valve was also done, a Bentall or some other type of procedure like that, you would click yes for the aorta procedure performed, and then when you get down to valve, you can still click yes here, and then answer the question about valve explanted, and then for the aortic valve procedure performed, you would select yes, and then it's going to say the next question, if you select yes for aortic valve, it's going to ask you again, was this procedure performed on the aorta as well? This is going to be the parent to this M2 section, and K1 will not open. So the valve sections are now labeled K for the explant, K1 for aorta, K2 for mitral valve, K3 for tricuspid, and K4 for pulmonic. So that's just this is going to be apparent to the M2 section along with this aorta procedure performed. And I'll show you a little bit as we get down further how that works. So again, for coronary artery bypass procedure performed, nothing changed there. The aorta procedure performed, you would still select yes for aorta, even if it was a combined procedure. For valve procedures, if it's a combined aortic valve and aorta procedure, you would still select yes here and just answer if the procedure was performed on the aorta as well. Mitral valve is the same and tricuspid is the same with pulmonic. And then I'll explain more in detail on this section when we get down to M2 so you can see how that works. It's a little bit different than what we've seen previously, but it should be able to help you collect things all in one spot so you don't have to collect information in K and then go over to M2. Everything will be collected right in M2 for these combined procedures. The next question that was added back in is this mechanical assist device, ventricular assist device section. And this was a mechanical assist or VAD present on admission, implanted or explanted during this hospital procedure. And this will open section L. Section L is the mechanical assist section, and it did not have a parent in version 2.9. So this will now be the parent to that field, so you don't have to go in and enter any of those other questions if there was no VAD or mechanical assist device inserted or explanted or present on admission. We had some changes in the AFib section, and we'll talk more about that. This is other cardiac procedure except AFib, same as 2.9, and AFib procedure, same as 2.9. When we get down here, I'll show you that we moved out the AFib section. We were kind of double capturing those maze procedures and things like that. in section M and in section M1. We're just going to capture any type of procedure done for either current AFib or to mitigate AFib in section M1 instead of double capturing those. So I'll show you what that looks like when we get down there further. Other cardiac procedures, we have except unicuspid, bicuspid, or quadricuspid valves will go in this section, and then other non-cardiac procedures. No major changes here. Let me make sure I'm not missing anything here. The OR date and time and exit time, that's all stayed the same. The change here, we did remove intubation date and time. If sites want to capture this themselves, they can go ahead and do that as adding it as a custom field. Or you can use your vendor software or your EHRs to query that if you're checking your total intubation times. What STF is interested in is the time from OR exit to their initial extubation and any subsequent intubation periods. So we do not need this intubation date and time field because we're going to use OR exit date and time for the initial intubation date and time to calculate any types of prolonged vents or things like that. And then this anesthesia end date and time has been removed. This field was very difficult and varied from site to site and from patient to patient. Depending, some sites were collecting it when the patient left the OR. Some sites, anesthesia stays with that patient for quite a while afterwards. So we removed this because it didn't provide us much information that was reliable. The only other part where this came into play is when we were looking at postoperative glucose, and we'll get to that when we get down into the postoperative section and talk more about what we made there for that change related to removing this field. Okay, almost done with this section, and I see a couple questions, so I'll go in and see if we can answer a couple of them as soon as we get through here. And then perfusion strategy. So we changed this name. It's still the same field, but we changed from CPP utilization to perfusion strategy, and we added in left heart bypass. And these are mainly for aorta cases, so you're able to collect that type of perfusion strategy. And if you use combination full or left heart bypass, then we are going to collect the cannulation sites. We did remove cable by cable. This was an extremely confusing for sites regarding this type of cannulation and when to code it. So we did add an SVC to kind of replace this, because what we're really looking for is to see if that cannulation went into the SVC. And then let's see here. We have, let's see if I missed anything. Oh, the temperature source. Sorry, I skipped ahead of myself here. For the temperature source, we added in the oxygenator arterial outlet blood, the CPB arterial blood. It seems that sometimes this is actually the, I want to say that this is the most accurate, but we'll provide clarity in the training manual, and Melinda can probably talk on this further after we get through this section. I'll have her explain a little bit further. We're looking for sites to be consistent and to look for core temperatures. I think what we said about this is that this sometimes, I'll have Melinda talk a little bit further on this. I don't want to talk incorrectly. I believe that we said that this is probably the most accurate one, but we'll let Melinda talk on that. Okay. And then we did add in lowest hematocrit. So if your patient goes under, so I already had a question on this, so I'm going to be a little bit clearer in this description. We have perfusion strategy, so none, left heart bypass, combination, full. And then we get down to circulatory arrest. And the next question is, what was the patient's lowest hematocrit during CPB? This is a child of circulatory arrest, because what we're looking for is increased stroke regarding the patient's hematocrit during CPB. So that's why this is a field under circulatory arrest. So this is during CPB, what was their lowest hematocrit, so after initiation of CPB. And then we also added in cooling time prior to circ arrest, and this should be documented in your perfusion records. We worked with when we went through this upgrade on this section, we did work with a couple, the Perfusion Society and a couple other perfusion groups to review these sections, and added things in here that would be really helpful in kind of tracking stroke rates and things like this. And that's the same thing with this cooling time prior to circ arrest. This also has to do with increased stroke rates. And then we get down into the diffuse aortic calcification. We did remove this, and the assessment of the aortic, of the ascending aorta and arch for plaque. This was removed because there were so many different methods out there that are being used. Some palpate, some use TEE or things like that to assess the aorta. So we removed this question, and we weren't really doing anything with it. We would capture this in the preoperative risk factor section as well. And then we get down to, this is the blood product section. Intra-op blood products, yes, not given, or no patient refused. Patient refused was added on here for patients who refuse blood products. Fresh frozen plasma and plasma units, we will clarify this in the training manual as to exactly what this means. Units can be made up of a combination of so we have clarifying language in the training manual that we worked with the surgeons on for that, and then the same thing with the dose pack for platelets. For intra-op clotting factor, we added factor 8. And then we get into the intra-op antifibrolytic medications. We made these a select all that apply, and here are the choices. We added a protein here. This is used, I think, in Europe mostly, but the surgeons asked to add that in our, so we did that. Actually, I think our anesthesiologist asked. And then we get down into the intraoperative TEE performed, and we added no prosthetic valve. When we have our missing variable report come back, or our DQR come back, we're going to work with IQVIA that if this intraoperative TEE performed post-procedure is marked yes, and we have any answer filled in for any of these fields from this first sequence 2565 through 2582, if we have any answer hit in, then it will not show up as anything else that is not filled in will not show up as missing. We're unable to have differing field types for the same numbers. That's why we have like mean aortic gradient. We're not able to add, have a value and then add NA here. So that will help just because that's the way databases work. So to get away from all of that extra missingness, we will just make it so that if you choose yes for TEE performed and you choose at least one of these fields is filled out within this section, the missing for the others will not be shown. And then surgery followed by planned PCI. And that's, I'm going to stop there for a second and see what kind of questions we have in. I'm going to kind of move these COVID ones over. Okay, and then I have this, when will the training manual be updated? What is the ETA? So Melinda, are you on the line, and did you want to provide an update on the training manual?
Yes, so I'm hoping that it will be done by the end of May. It's a long process, and it goes through lots of different people's approval. So I'll tell you right now, I myself have gotten through every section except 2. And we have quite a few sections out for core group review, Carol review, and then we involve the surgeons. So we're at different stages with different sections, but I'm really hoping that the end of May we'll have it done.
All right, sounds great. Thank you. I know we're working hard and trying to get everybody involved along the way with the different steps of the process. There's a question. The next question is for a patient who arrives with an NSTEMI, then on day 7 goes to the OR, we capture cardiac presentation, or how, I guess they're asking, how do we capture cardiac presentation? So we went over this field on the last call, and I'm just I'm not going to take much time on it, but what we had said, I'm trying to find it in here, is what we had said is that you're going to code the reason why the patient, what was the reason why the patient ended up having surgery. And I can't seem to find that on here quickly.
Well, it would be the worst CAD presentation. So if this patient presented with a non-STEMI, then that's how it would be captured.
Great, thank you. In the incident, thanks Melinda. In the incidents, what is NA not a CT surgery mean? So if you're filling out this form and you're entering in things other than the CV surgery, some sites do enter all of their cases that are performed in their OR in the STS in their STS software. For whatever reason, they found that useful at their site. So this was a requested field when it's not a cardiovascular surgery to have that. If we are working from home, how do we capture 30-day status if not known? I won't use my personal phone. So just do your best. I would check if you still have access to your EHRs. You can check your EHRs. I'm going to ask that you just please keep a log in any steps that you're doing to do any type of follow-up, I think is appropriate at this time. For the operative reason, under urgent, no, I have, so somebody just clarified, or provide something in the chat box, not a CV surgery is used for TAVR collections. No, that's not true. So TAVR collections are still CV surgery. You still need to be entering those as CV surgeries. Not a cardiovascular surgery is anything that's other than a cardiovascular surgery. TAVRs are still cardiovascular surgery. Next question. For the operative reason under urgent, emergent, and emergent salvage, would you considering adding patients on ECMO as a reason? So I don't know that all patients on ECMO, I don't know that ECMO automatically means that that patient is an emergent, urgent, or emergent salvage. They need to fit some of this other criteria. If they had an AMI, or if they have unstable angina, or whatever that other, whatever that leading cause that patient being on ECMO, I think would probably be the most or the best thing to choose. Melinda, do you have anything to add to that?
I'm sorry, Carol. I was actually looking at that NA for not a cardiovascular surgery very quickly, and I missed that question.
Oh, that's okay. They just asked about, yeah, go ahead. Sorry.
I wanted to clarify that the TAVRs and endovascular procedures for incidents really aren't considered as entry into a space because they're endovascular. So I think I'll work on that in the training manual so that's a little clearer. And if you can repeat that ECMO question.
Sure, thank you. So the patient, for patients who are on ECMO, they asked to add that as an urgent, emergent, or an emergent salvage reason. And I was saying that we should be coding the reason why that patient is on an ECMO, if it's related to an MI or if it's worsening chest pain or unstable angina. That would probably be the most appropriate way to code those patients.
Yes, that is correct. And then, of course, if the patient goes in on ECMO, then that would be an emergent salvage for the status.
Great, thank you. So will we no longer need to capture canceled cases? No, we are not capturing canceled cases any longer with 4.20. You should still capture them. All of these changes are related to 4.20. You still will capture canceled cases in 2.9. We don't want to change what we're doing for 2.9 because we won't have complete data sets. So please continue capturing those for 2.9. But when 4.20 goes live, then that's when we'll make that change. Next question, are you allowing for only one valve explant? So I think we have more than one valve explant. I think we've talked about that, right, Melinda? We added a couple.
I think there's 3 actually now. We added up to 3, yep. I believe.
Yep, so we have 3 now. We have 3 valve explants. Next. These types of things make it more difficult when doing data retrievals. It would behoove the STS to keep this in mind when making changes for new versions. Trying to do retrievals over several versions can be a nightmare. So we'll be happy to provide you with any types of mapping that would help you pull out data. And I'm not sure exactly what these types of things was referring to in your statement, but we're happy to help you pull out. If you need help with mapping, we're happy to help you with that. Next question, should we abstract on an isolated pericardial window case in 4.20? This is currently conflicting information in 2.9 manual on whether to include these cases or not. Melinda, could you clarify that?
Yeah, those are optional entries. Some sites want to enter those in and some choose not to, and they'll continue to be optional.
Great, thank you. When will a new PROC ID table be available? Additionally, will it be presented in a more user-friendly format? So actually, our next call will be regarding PROC IDs and regarding the 2.9 PROC ID table. There will not be many changes from 2.9 to 4.20 in the PROC ID table, and it will not be presented in a different format. We will use the format that it's currently in. And if you're able to join the webinar on April 1st, we will be going over how to read the PROC ID table, because I think once it's explained a little bit different than just looking at a whole bunch of bullet points, it might be a little bit easier to understand and read. Why are CPT codes needed? We do not abstract that data. We do not abstract that data. So I think we use the CPT codes, and Dr. Wormuth, if you're on and available to speak, I believe we use those CPT codings to look at the data across them when we get the Medicare files. But I'm going to see if Dr. Wormuth is on and would like to expand on that any further.
Can you hear me? I keep dropping in and out of Zoom, so I don't know if the audio is going to go. So the CPT codes were mainly there as a hint to the billers, at least on the thoracic side. For adult cardiac, I think you do collect them, so we can just kind of follow trends and look for new things. But primarily the way we analyze is just by the broad category procedures. And because we can't change as fast as the CPT codes do, we really haven't tried to tie ourselves directly to them. If they put a new one out next year, we're going to lag it by 3 years just because of the way we do our updates.
Okay, thank you very much. Yeah, we don't keep a list of CPT codes for STS. We usually refer sites to their billing departments to get those CPT codes, just because they do change so fast, and we don't want to provide a list that's not an all-inclusive list at the time of your abstraction. So we would hate to give you something and it not include everything you're supposed to be abstracting. But like Dr. Wormuth said, those are primarily used for billing. So I appreciate that. Thank you, Dr. Wormuth. What is the link for the removed fields highlighted in 2.9? I'm not sure what you mean by that, Ron. If you could provide some more information, I'd be happy to answer that. Will benchmark procedures change for 4.20 version? No, the benchmark procedures will stay the same. I do believe we're coming out with a double valve model that will be in place. That is one of the PROC IDs that's currently there, but not risk adjusted. I do believe that risk adjustment will be coming out shortly in the next few months. We're still working on it or finishing it up in our quality and metrics task force. Explain again how total intubation is going to be calculated, or is this not going to be an event greater than 20? So total intubation has been and will continue to be calculated from OR exit time to initial intubation time plus any additional intubation time. That's how we calculate, and prolonged event will still be an adverse event. Can you explain the rationale for removing extubation date and time? So we did not remove extubation date and time. We moved that down into another section, and then we'll get there. Let me find it on the screen here. Hold on one second. So the things in green just mean that they were moved from this section to another section. This was moved down into the post-operative section, where we asked if the patient was extubated in OR, their initial extubation date and time, any additional intubation, total intubation hours, and if it was a prolonged event. So all of the intubation and extubation fields are in the same section. We do lots of cerebral perfusion without circulatory arrest, still cannot enter the cerebral perfusion time. So I believe your cerebral perfusion time is here. Oh, I see what you're saying. You do it without circulatory arrest, so you enter no. I guess I don't know that I knew that was something that we needed to look into, but we can review it for the next upgrade and how to do that. You can always add cerebral perfusion time in for patients who are don't receive circulatory arrest as a customized field if it's appropriate for your hospital with your vendor software. But I will put it down as a note, as something to look into for the next upgrade. In the lowest hemoglobin and lowest hematocrit, it is listed twice. Once the lowest intra-op and then again lowest during CPB. Won't they basically be the same? They could be the same, but not necessarily the same. Okay, does STS suggest any mandatory fields for vendors to implement an abstraction page for 4.20? So we have fields that are mandatory for the vendors to make allowed for abstraction and that are mandatory to be submitted in to the data warehouse, if I'm understanding your question right. And Paul Meehan, if you're on the phone and you can hear me, do you have anything to add to that? This is regarding the mandatory fields for vendors to implement an abstraction for version 4.20. Okay, it sounds, and Paul might not be on, but it sounds like we do have fields that are mandatory for vendors to provide for abstraction and that are provided for submission to the warehouse.
Oh, actually, I am here. Sorry, I was wrestling to find the mute button.
Sorry.
Yeah, all of the fields are required. So I don't know if I'm understanding the question, but yeah.
Okay.
So like that, they should all be included. There's just the optional fields for the PHI fields, but those fields will be extracted, just not containing any values. I don't know if that's the question or.
Okay, I'm not sure, Jennifer, if you have any more information on that and you want to put it into the Q&A, please feel free. Next question, where can we find the form on the left, the 2.9 version with the highlighted changes? I was going to post it and then I decided not to post it, and I'm not sure why I decided that, but there was a reason. I'm happy if, let me see if I can post it. I think I wanted to get through it and explain the changes first and then post it. But if it's easier for everybody, I can also, I guess I could just post it and hopefully that people are patient with these webinars and refer to the webinars for their answers before emailing. So we can do that. Is there any logic for specific measures in the STS national reports that STS would send to vendors to create reports? So I'm not sure exactly what you're referring to, but we do have inclusion/exclusion criteria available, and it is on the website. Next question, what data field would RIA-strap be captured in? And Melinda, do you know about that?
Well, we don't currently capture that. RIA-strap is a fibrinogen, that's man-made protein, and we don't have any place to capture that in the current version.
What is it used for?
It's fibrinogen. That's given human concentrate. I think that was one of the questions I had for the surgeons as I was going through, because this question actually came through the FAQ a couple weeks ago, if I'm not mistaken, whether we would capture this as a clotting factor or not. And I haven't gotten it.
I think that they had said no to that. So we can revisit it and maybe clarify in the training manual on that one. It would go here, right?
That's what they want to know, if it would go in there. And right now we don't capture it. And I have a question in the ops section for the surgeons to see if we want to capture that in the new version. That's not been decided though.
Okay. All right, we'll have to get back to you on that one and provide clarity on it. Is there nowhere to type in the actual extubation date and time? So it's down in the, it's moved down here. I'll show you where it's at. So here's the, we did put a field in here. I'm not going to go over this part, but it's down here in the extubated and OR, and then initial extubation date and time is here. It's moved down to the post-operative section. Okay. Okay. Since cancel cases were removed, would it be correct to assume that we no longer include those cases in the database? That's right. You don't have to put your cancel. You should still put them in for 2.9, but not starting with July 1st OR dates. Do you know how many data points were collected in version 2.9 and how many are collected in version 4.2? So the change is about, it was about between 30 and 34% decrease reduction in the number of variables that are collected at the site level. That does not include counting the variables that are calculated in the background by your vendor software, which are things like the risk model scores and things like that. So there was about a 30% reduction in the number of variables that are collected at the site level. Is there a lead extraction case considered, is a lead extraction case considered a not cardiovascular surgery? And I don't want to confuse anybody on this, Melinda, so do you know how we're instructing sites to code those lead extraction cases?
Okay, so this is a two-part question. First, are they required for the database? So laser lead, open lead extractions we have required in the past because it puts the patient at a significant risk that things could go wrong. And yes, it's captured as a cardiovascular case.
Okay, thank you. And could you speak, Melinda, could you please speak on the NA not a CV surgery? I thought the T-bars were.
Yeah, in the current version, as far as I know, this isn't changing for the new version. Any of the endovascular procedures such as TAVR, T-bars, mitral clips, you know, they're catheter-based procedures. We do not consider them cardiovascular surgeries with regards to incidence, which is the field that we're talking about here. Because it's catheter-based and you're not really, you know, going through a pleural space or a pericardial space and things of that nature. So I hope that clears that confusion up.
Okay, thank you.
Okay.
Yeah, so, okay, thank you. And then the next question is the TAVRs. We were told not required to enter TAVRs if we participated in TBT registry. Is this not true? No, that's true. You do not need to enter your TAVR cases into the STS registry, but some sites do enter their TAVR cases in. Next question. Regarding follow-up on 30-day mortality, I also work from home. I have my office phone forwarded to my cell phone. When I call a patient from my cell phone, I use the *67 feature to hide my cell phone. So I appreciate that, Peggy. Thank you for putting that in here. If you're doing your 30-day follow-ups and you usually call your patients and you're still able to follow up that way, you could use the *67 feature on your cell phone. I think there's also a way on your cell phone settings to change that so your number does not show up on the caller ID. When will the surgeon's worksheet for each procedure be available for version 4.2? We may need to tweak them a little before use at our site. So we'll get those available probably sometime in May or June. For example, what would be considered not a cardiovascular surgery? So like Melinda said, it sounds like things that are, and Melinda, do you want to speak on this? It sounds like things that are used through catheter-based would not be a CV surgery?
Correct, as is in the training manual right now.
Okay, thank you. I apologize for that confusion. I automatically think of valves and I think of a big valve procedure. And I forgot that we had put that in there. If we are entering TAVR procedures into the TBT registry, are we also supposed to be entering the same data into the adult cardiac? You are not required to enter TAVR procedures into the into the adult cardiac registry. Some sites do double capturing just because they like to have the same data set for those TAVR patients as they do for their SAVR patients, the surgical aortic valves. It's totally up to your site and what your surgeon and quality department want to do with those cases. So Michigan advised us to use NA not for cardiovascular surgery for our TAVRs. That's correct. Do not use NA, and I apologize for that confusion. Do not use, or I'm sorry, please use NA not a cardiovascular surgery for your TAVR patients. I apologize for that. TAVR cases are not analyzed, our TAVRs analyzed. TAVR cases are not analyzed procedures in the STS database. They go into the other category. Okay. So there seems to be quite a bit of, I just had the 5 or 6 questions come through asking again about TAVR cases in the STS registry. TAVR cases are not required to be entered into the STS registry. If you participate in the TVT registry, which is the mandated registry per the CMS NCD, then you need to enter them into the TVT registry. They are not required in the STS registry, but some sites do double capture them. Requesting clarification for canceled procedures. If a patient is in the OR, surgery aborted after incision, would we not abstract that aborted case? No, you don't abstract that case. Do you have any clarification on that, Melinda?
Well, I think for newer abstractors, probably within the last two to 4 or 5 years, that's when we added canceled cases in. Before that, we never captured canceled cases, and we're going back to that again. So this may seem strange to those of you who are newer in this profession, but I think it'll make it easier in the long run, and you won't have to be capturing those canceled cases.
Great, thank you. And I see questions coming into the chat box, but we are not answering questions in the chat box. So you'll need to submit them in the Q&A, please. Next question. Just to clarify, what are the 2 links to the 2 forms you are currently displaying that have the highlighted fields? So I will post this, the one with the blue highlight and yellow highlight. I will post this. The one with the blue highlight is available, and I'll show you where that's at. Hold on 1 second. See if I can end. Oh, here we go. Let me pull it up on my Google. If you go to Registries and Research and then the STS National Database, and under Adult Cardiac, and then, version 4.20, and the annotated data collection form does not have any highlights, and the highlighted form is the one with the blue. So that's where that's located at. Our coders do not code CPT codes on our inpatients. We cannot collect this. Okay, that's fine. We would like it if you could submit it. That's fine. If you're not able to provide that information, okay. Where did additional antibiotics dose given go? Is it removed?
Yes, it got removed.
I must have skipped over that one.
It got removed, Carol. We're not doing that additional dose given anymore.
Okay. Thank you. What is the other acceptable reason not to use? We didn't get down to the cabbage section yet, but I'll be happy to answer the internal memory questions when we get down there. Next question, please clarify extubation time is when weaned off a vent versus extubated. For instances when patient is extubated to move to a trach but remains on vent. And Melinda, did you want to take this one?
Yeah, Debbie, if your patient goes to a trach and they're still on the requiring mechanical ventilation, that's still ventilated patient. So they would need to be removed from that mechanical ventilation before you stopped counting the ventilated hours in that scenario.
thank you. If we have one explant valve, do we click into the two others? No, those are, I believe that they're children of the valve, the other explants that are in front of them, but we will explain that a little bit further when we get down in that section. Will these answers and questions be posted somewhere so we can see the answers to the questions we missed? So it is recorded, and you're welcome to go back and listen to the recording. I'm not going to go through and type the answers because it is recorded and we're answering them live. That's kind of the benefit of joining and listening. If we had more resources, I would be happy to provide that, but we simply don't have those resources available to provide that. Would it be possible to provide a crosswalk of 2.9 and 4.20 fields in an Excel rather than PDF and include the name of the field as is shown on the form, and that would be much easier to evaluate for the changes? So we do provide a change document that is in PDF. I'm not sure that I'm going to go through and make this crosswalk available because we provide all of the other documents. I think that's a good exercise if you have time to do it, but we did provide this, the data collection form this time with these changes marked to hopefully help with that as we had been requested with the last upgrade.
And Carol, those changes are in the PDF document and an Excel spreadsheet.
Oh, do I have the Excel spreadsheet? It's an Excel, not one column against the other though, right? It's,
oh, no, not comparing it's the itemized changes from 2.9 to 4.20.1.
okay. I'm not sure if we have that posted yet online.
Okay.
We were waiting for the vendors to finish their build in case we had to make any changes.
Right.
Okay. Are the risk model coefficients in 2.0 different from 2.9? If yes, will the variable coefficient table be released along with the database release? So the variables stay the same. The coefficients will probably change a little bit to make that O to E back to 1, equal to 1. But we post the coefficients basically will stay the same. Is there a time frame from when surgeon data collection forms will be available? So I'll try to have those hopefully in June. Can vendors change a checkbox to a drop down? I'm not sure exactly what you're referring to, and things where we have lists and you have to pick, I believe they have drop downs, but Paul, do you want to speak on this one any further? I'm not sure that we...
Yeah, I think they should not have checkboxes. They should have choices for yes and no, not checkboxes.
Mm-hmm. Thank you. When will the final update of version 4.20 be ready to print for July 1st use? Will there be any further updates or changes to the current 4.20 data packet? We're not expecting to have any changes to it, so it should be in its final form now. If there's any changes, it's small things like spelling errors. I think there was a few spelling errors in the data specifications, but not on the data collection form. We should be good to go with that. What fields are optional so we can limit the PHI shared? Is there a list? If your site does not care to share PHI, you do not have to submit it into the database. Is there any reason you only want the cooling time prior to circ arrest, not the total cooling time or temperature? Sure, the cooling time prior to circ arrest is an indicator of stroke after surgery. That's why they're looking at that field. Will there be updates made to the procedure identification table algorithm? Yes, there just slight changes, but not many. And we will post that. On our next call, we will go through the current Proc ID table. Just to clarify, Melinda, this is for you. Just to clarify, should we be capturing all standalone valve removals? I'm sorry, lead removals.
Laser lead extractions and things of that nature that require open procedures to remove those leads are to be collected as it stands in the version 2.9.
Okay, thank you. What are pericardial windows considered for CV incidents? That's for you, Melinda.
Well, pericardial window, technically you're going through the pericardial space. So I'm thinking, you know, if it's a first procedure, it's going to be a first incidence.
Great, thank you. All right, Dorothea told me that lead obstructions were voluntary to enter, and I apologize, Melinda, what you had just said on this. If surgeons wanted them, I've never entered them. Also, convergent procedures, Dorothea said it was up to the surgeon if they valued the data being entered, otherwise not mandatory.
As it is in the training manual, both of those are mandatory. So I don't know at what point that communication was given to you, Kathy. Send me a little email in the FAQ mailbox, and perhaps we can continue this conversation there.
Thank you. Clarification, if the patient just has a lead obstruction, do the cases get entered into the database? So as Melinda said, yes, those cases should be entered into the database. Dr. Bavaria asked sites to enter TAVRs, and TAVRs are not required for the TBT, for the STS registry. They are required for the TBT registry. If your site would like you, if Dr. Bavaria asked you to enter the TAVRs, then please enter them into your registry. It is up to the site, their surgeons, and the quality departments if you are to enter TAVRs into the STS ACSD registry. No, TAVRs are not in the other category. They are not analyzed at all. Right? They fall into the other bucket and they are not analyzed. I'm not sure if the analyzed cases are not analyzed at all. They are, I believe that they are still counted in your total for, not in your total for TAVR cases at the end of your report, but I'm not 100% positive on that, Cindy. I apologize if there was confusion, but they are not analyzed. That's correct. So just to clarify, we have to include laser lead obstructions in the database.
Currently, we do. I think with all this, with all these questions, Carol and I probably need to talk to the surgeons about this. But as it is in the training manual now, we've asked that for those to be entered, open procedures that remove lead extractions.
Yeah, and I think that Dr. Shahian had been pretty clear on this in a couple of our core calls. The reason why these are entered is because of the high risk that's associated with these lead extraction cases, that they should truly be entered into the database. But I think it's good. We have gotten quite a few questions, it seems, on these, so it's really good to readdress this, and maybe it's something we also need to cover with AQO. Cases that go in and cases that don't need to be entered. For anyone who attended STS meeting, they should have a copy of the color forms. Yes, but these forms were handed, the 2 data collection forms, actually 3 data collection forms were handed out at AQO, so hopefully you still have those handy. The one with the color changes, the blue, the green, and the yellow, this form has not changed. This is the same form that was handed out at AQO. Is there an itemized list of fields that are new so we can analyze that to evaluate potential changes for documentations, a list and not a DCF? So I'm not sure that we have new cases that need to go in, or itemized list of fields that are new. I see, the itemized list of fields that are new. There is the document change or the version change from 4.29, from 2.9 to 4.20. If it's not posted yet, we'll have it posted after the vendors start getting certified in case there's any changes to it. So canceled cases in OR does not need to be entered or abstracted. Canceled cases do not get entered into the database. Why did we remove the additional antibiotics? Is that not best practice anymore? So it's not that it's not best practice anymore, it's that there was a lot of confusion about when that antibiotic was given, when it should be counted as an additional antibiotic, if it was out of that 4-hour time window. If it was after that 4-hour time window, it was appropriate, but what about patients that got it at the 3.5-hour time window? That's still an additional dose. So there was a lot of confusion about when that additional dose was given, and we couldn't be certain that the data that we were getting in was as clean as we would have liked it to be to really do anything with it. So it does not mean that it is not best practice anymore. It just means that we're not collecting that field. Is the STS data collection form available electronically that we can enter the data in the form and save it in a file within our PC? No, we don't have a fillable form available. That's what your vendor software is for, or that's what the vendor's software is for, to do that electronically. And lowest hematocrit during CPB under cardiac arrest versus lowest hematocrit. So your lowest hematocrit, it can be the same value, either pre or during CPB, but it could also be different. So you could have a lowest hematocrit with that patient who either pre or post CPB, or you could have a lowest hematocrit during CPB. Those fields, the lowest hematocrit during CPB is a different field than the lowest hematocrit during the procedure. However, those values could be the same. So if they're the same, that's okay. If you have a lowest hematocrit, whatever the lowest hematocrit is during CPB is what gets coded in that lowest hematocrit during CPB field. You removed CPB utilization and replaced it with perfusion strategy. Why are you still referring to CPB for perfusion and not perfusion strategy? This could confuse new abstractors. I'm not quite sure what you're referring to, Robin. If you could provide some clarity on that. Thank you. Our laser lead extractions are done by our EP doctors. So you'll enter your laser lead extractions that are done by the surgeons that are listed on your Schedule A with STS. If any of them are done by your EP doctors, then they do not need to be entered into the registry. I agree on lead revision. I was communicated that same thing. Those cases are also placed in the ACC CDR database. So the lead abstraction cases, the lead revision or lead abstraction cases, if they're done by EP, then they probably go into the ACC database. If they're done by your STS surgeons, they should go into the STS database. This may be more of an FAQ type question, but since we are here, if you have a patient that has a valve disease and it gets a lima, patient has stable angina but also has symptoms from CHF, do we code stable angina or other for cardiac status upon admission? I'm not sure the question, Heidi. If you could just submit that to the FAQ so Melinda can answer that, and so we can stay on task during this call. And I have just about 1 minute left, so I'll see what we get through here. We already answered 90 questions, and we have 30 more left, so I'm just going to stay on just for maybe one more question. We have always been told pericardial windows and lead abstractions are not mandatory. So we just said that. Yeah, and then Cindy from Northwestern says that they've always entered them into the database because they are quite disastrous at times. And just there's tons of questions on here about lead abstraction, so we will provide clarity in the training manual. Okay, thanks, Cindy. So no TAVRs, they are not analyzed, and they are not in totals in the case counts. Okay, thank you for clarifying that. Okay, I guess we're going to end there. Lots of questions about lead abstractions and pericardial windows, so we will provide some clarity in the training manual on that. I don't have, let me get my slides back up here. Hold on. There we go. So here are our next webinars. We have April 1st, we have our monthly call at 2 p.m. and we're going to go over the PROC ID, the risk model variables, and the range values because we had some confusion on those range values. So we'll provide some clarity on those, to explain a little bit how the risk model variable works and then how to read the PROC ID chart. April 15th, we have a user group call, and then April 30th, we have the next upgrade call. There will not be any calls regarding the IQVIA platform in April because we have a lot of other things to talk about regarding the PrAC IDs and things like that, and not a whole lot going on right now with IQVIA. The submission is still open, or is open, so you can enter your data and use it. We will answer questions regarding IQVIA on the user group call if you have them. They will be on the line with us, but the other 2 calls during the month will be just specific to database PrAC ID risk model variables, and then the upgrade later on in the month. So I hope everybody's staying safe and taking care of yourselves. Thank you so much for joining, and I hope you have a great rest of the day. Thank you, Melinda, for joining, and I
Carol,
hope...
Can I just say one thing before we get off? Pericardial windows are optional to enter. I see there's tons of questions, so I'm just throwing that out there right now.
Thank you. Yeah, and we can revisit the pericardial window thing hopefully on the next call, or we put some clarification out there in the training manual for everybody so we can see specifically the pericardial windows and the lead extraction. I think we'll just have to help people with that, and we probably have had some communications that were crossed between different folks answering questions for us, so we will provide as much clarity as we can regarding those, and I apologize to anybody for any confusion that has been caused in the past, and going forward we'll do our best to try to get you the best information to make sure that cases are entered consistently into the database. I know the better direction we give you, the easier it is to do your job, so we'll help you. We want to help with that. Well, I hope everybody has a good rest of the day. Thanks again for joining. Please feel free to reach out if you have any questions or anything, and we'll do our best to help you with things. Take care of yourselves, and we'll talk soon. Thanks, Melinda, and thanks everybody for joining.
Bye-bye.
Bye.